before anesthesia and/or surgery. Too long a fasting period can result in dehydration and hypoglycemia, or low blood sugar. It's critical that you discuss when you should stop eating and drinking with your anesthesiologist. The majority of patients appreciate being made aware of the process regarding their surgical event. The buildup of anxiety preoperatively is one of the most common complaints expressed by patients, particularly for outpatient surgery. The patient and anesthesiologist talking through any outstanding issues of concern usually alleviates anxiety. Sometimes anti-anxiety medications are prescribed. You may be wondering what happens when there's no time to carefully prepare for surgery. A gunshot victim, a head-on collision, an appendicitis attack. In the case of these emergency situations, the medical team on call will strive to take care of the problem while exercising a high degree of vigilance. Patients are carefully monitored for increased bleeding, blood pressure changes, appropriate fluid levels, heart performance, kidney function, and so on. In other words, the emergency care team has to imagine that any conceivable problem can and will occur. Television shows and movies do not begin to reflect the intensity and drama of real-life situations in the emergency room. Now it's time to explore the most commonly asked questions we mentioned at the beginning of the video. By far the most frequently asked questions are, will I be awake during surgery? And will I have awareness of the surgical event? In order to answer these questions correctly, we need to first consider the type of anesthesia prescribed for your procedure. You and your anesthesiologist or surgeon will likely have discussed whether you could expect general, regional, local with sedation, or some combination during your consultation.
Regardless of the type of anesthesia, any visit to the operating room will include monitoring devices to measure vital signs. Equipment is routinely used to measure blood pressure, heartbeat, pulse, the concentration of oxygen in the blood, and body temperature. In the case of general anesthesia, analysis of inspired and expired oxygen, carbon dioxide, nitrous oxide, and/or anesthetic gases will also be measured. The most common type of anesthesia used in surgery is general anesthesia, where the patient is rendered unconscious for the duration of the surgery. Some examples of commonly performed surgeries where general anesthesia is typically used include general surgeries such as bowel surgery or gallbladder surgery. Brain and heart surgery require deeper levels of anesthesia and are done under general anesthetics. Many types of cancer surgeries, as well as some plastic surgeries, are also done under general anesthesia. There are certainly many more operations that typically are performed under a general anesthetic. Administering a general anesthetic is a two-step process. The first step involves getting the patient to sleep through the use of an induction agent that is generally given by intravenous injection. An induction agent acts as a bridge to take you from your current state to a surgery-ready state, but it does not generally keep you there. Commonly used induction drugs include propofol and pentothal. There is often a question regarding the use of a mask for anesthesia. A mask is commonly used to administer oxygen just before or at the beginning of administering an anesthetic. Think of a mask as a means to an end. In some situations, the mask provides the pathway by which anesthetic is introduced, but in most cases, it is simply providing oxygen for the patient's safety before the anesthesiologist gets more definitive control of the patient's airway. Today, it is relatively uncommon that a mask alone would be used continually to administer gaseous anesthetic agents for the duration of surgery. Fortunately, the days of smelly, multiple-washed black rubber masks have gone the way of ether. In other words, they are of historical note and not of current concern. Current masks are clear, lightweight plastic with no detectable odor. Complaints of difficulty breathing and a sense of claustrophobia are rare. Some adults may recall reported liver damage with some anesthetics, halothane hepatitis. Others may have heard stories about severe nausea, delayed recovery, and coughing with ether. Fortunately, ether is no longer used, and halothane is primarily used in veterinary applications. To keep you asleep, we use a maintenance agent, sometimes intravenous, but usually gas. Those most commonly used include agents such as desflurane, sevoflurane, and isoflurane. Each of the agents commonly used has advantages and disadvantages. Your anesthesiologist will try to match the surgery you are having, your health, and the best available agent for you. Because of the possible side effects of a gas anesthetic agent on an individual, more than one gas or inhalation agent should be available. Nitrous oxide, or laughing gas, is sometimes used to help reduce the dose of inhalation agent you receive. Nitrous oxide is not strong enough to get you safely fully asleep, but is used as a supplement. Sometimes it is important to partially or even completely paralyze the surgical site, as in abdominal or cardiac surgery. Some muscle relaxants may still be working as you are awakening. The anesthesiologist has the drugs, tools, and knowledge to safely monitor and manage the temporary drug-induced paralysis or weakness caused by muscle relaxants administered during surgery. In unusual situations, the relaxant effect may not be able to be completely reversed as you are waking up, and you may need to have a ventilator or breathing machine help you breathe for a while. Surgeons and surgeries vary widely in their needs for the use of muscle relaxants during surgery, so your situation will be customized.
So far, we've discussed getting you to sleep and keeping you asleep. Masks will generally not be the only device used to deliver the oxygen and anesthetic agent to you during surgery. You now know that a mask will rarely be used throughout your surgery. You also know that with a general anesthetic, you are unconscious. When you're unconscious due to the administration of a general anesthetic, you're unable to protect your airway, and your swallowing reflex does not work. The highest incidence of complications during anesthesia comes during gaining control of the airway. How then will you breathe?
The anesthesiologist can use several different methods. Sometimes a pathway for oxygen to get to your lungs is maintained with an oral or nasal airway. Masks always have some amount of leakage, exposing the operating room staff, the anesthesiologist, and the surgeon to the anesthetic gases. Since we do not want a sleepy surgeon, other devices are used to defend the airway. We need to be able to get oxygen to your lungs, where the oxygen and anesthetics are taken up, dissolved into the blood, and delivered to your brain and other organs to produce the effect of anesthesia. The first of these devices is called an endotracheal tube. Using a tool called a laryngoscope, the anesthesiologist places a tube through the mouth or nose and into the trachea, also called a windpipe. A cuff is blown up on this to create a seal. If this mode is utilized, we may breathe for you by squeezing a bag as seen on television shows, or by utilizing a ventilator, as is often demonstrated on episodes of Extreme Makeover. A ventilator is a mechanical device that breathes for a patient who is otherwise not breathing on his or her own. The laryngoscope has a light and a lever. The lever is used to gently move the tongue out of the way and gain visualization of the upper part of the trachea or windpipe and vocal cords. This allows the endotracheal tube to be carefully placed in the windpipe. This lever action is not appropriate for people with certain anatomic configurations, so other techniques are available. Your anesthesiologist will assess your upper airway, jaw anatomy, neck extension, and other airway features preoperatively to best prepare for you. Another method used to sustain breathing is an LMA, or laryngeal mask airway. Think of it as an internal mask. The advantage of the LMA is that it can be placed without the use of a laryngoscope. The disadvantage is a patient needs to breathe on his or her own during the surgery.
An LMA is commonly used when a difficult intubation is expected due to a patient's individual anatomy or when surgery will be brief. For shorter surgeries, it may be beneficial for a patient to breathe on his or her own, but for longer surgeries, there may be value to being able to breathe for the patient with a bag or a ventilator. Certainly for operations where the patient needs to be paralyzed, the endotracheal tube is preferable. Each of these devices is an excellent tool to help control the airway. All anesthesiologists are well experienced with both. Be sure to discuss any concerns you may have with your anesthesiologist in the preoperative visit.
In each of these situations, there is a common side effect of a sore throat afterwards. Whether an endotracheal tube or an LMA is used, there is a foreign object in the upper airway during surgery under general anesthesia. These areas, the mouth, the pharynx, the trachea, are sensitive to even minor irritation. Who has not had the sensation of a pill being stuck in their esophagus after swallowing it? Additionally, anesthetic gases are often not humidified, and as a result may dry out the upper airways. The sore or dry throat usually corrects itself within a day or two after surgery.
During surgery, the anesthesiologist literally has your life in his or her hands. While you're unconscious and unable to help yourself, the anesthesiologist monitors your life functions: heart rate, blood pressure, pulse, concentration of oxygen delivered to the tissue with each beat of your heart, temperature, heart rhythm, concentration of expired carbon dioxide and inspired oxygen with each breath we give you or that you take, and often kidney function. In certain situations, we also monitor brain waves, spinal cord function, anesthetic depth, pulmonary functions, and airway resistance continuously. We make sure there's no pressure on your nerves as you lie for surgery. We protect your sense organs, your eyes in particular, and provide treatments to reduce the chance of blood clots during lengthy surgeries. In addition, we need to anticipate the next step of the surgeon and need to know how fast the surgery is going. Anesthetics all take time to work, and the timing of additional medications or changes in doses of medications being given needs to be matched to the pace of surgery and the intensity of the surgical stimulus. We care for and control the environment of care, including all equipment to provide a safe and effective operating environment for you and the rest of the surgical team. We administer any additional medication you may need, such as antibiotics, anti-nauseants, muscle relaxants, heart and blood pressure medication, diabetic drugs. In other words, anything you might conceivably need for your safety and care in the operating room. In the operating room, your care is magnified even beyond what you might expect in an intensive care unit or ICU. You have a physician, the surgeon, taking care of the operative site. You have another physician, the anesthesiologist, minimizing the impact that the operation has on you. You have the rest of the surgical team, circulating nurse, scrub nurse, techs, concentrating fully on you and only on you. This concentration of caring individuals with no other task than your welfare does not exist anywhere else.
The depth of your anesthesia varies throughout the operation and depends upon the severity of the surgical intervention. Toward the end of the surgery, your depth of anesthesia will be gradually lessened as you transition back to awareness. The time it takes to recover from an anesthetic depends on the type of anesthetic used, the type of surgery performed, your health issues and medications, and to a certain extent, the length of surgery, among other things. With current anesthetics, there no longer exists a hard and fast rule that the longer the surgery, the longer the recovery.
Patients are often concerned that the length of surgery will increase the rate of complications. Surgeons share this concern. While there's some truth to this supposition for certain surgeries, open heart surgery, surgeries in the prone or face-down position, operations in the abdomen or on the great vessels, there is not for others. We're routinely able to have coherent conversations with patients after 12 hours of anesthesia being safely completed for elective procedures on the skin and body surface. With appropriate care, lengthy surgeries can safely take place. Discuss concerns you may have about the length of your surgery with your anesthesiologist. It's better for a surgeon to take the time to perform the operation properly than for there to be a rush to finish or a race to beat an arbitrary and often inappropriate clock.
Regional anesthetics work by blocking the nerves and numbing a portion of the body, usually through a needle and often through a catheter, in this case, a small tube through which drugs are administered. One of the most common examples of regional anesthesia is the epidural used in labor and delivery. A local anesthetic is given through the tube and into a space in the spinal canal outside the sac that contains the spinal cord and spinal fluid. The medication generally acts relatively slowly compared to intravenous agents, but a single dose may last from 1 to 4 or even 24 hours, depending on the drug chosen. In a well-functioning obstetric epidural, the abdomen is numbed, leaving normal sensation in the legs and the chest. The epidural space runs from the base of the skull to the base of the spine. Epidurals can be used in any age group, children to the elderly, and can be used for many surgeries taking place below the chin. Epidurals are also used postoperatively for pain control, particularly following thoracic, cardiac, abdominal, and orthopedic surgeries. Complications such as paralysis may occur, but are so rare that the statistics cannot even be calculated. The overall risks of regional anesthetics, including epidurals and others to be mentioned, are less than the risks of things we do every day without thinking, such as riding in a car or working in the kitchen. The benefits of a stable patient, possible decreased blood loss during surgery, and post-procedural pain relief clearly outweigh the risks. Other common types of regional anesthetic include axillary blocks or blocks in the armpit for upper extremity surgery, as in carpal tunnel release, blocks of the large nerves of the lower legs, such as the sciatic nerve for knee and leg surgery, blocks in and about the neck, which are sometimes used for carotid artery surgery, and field blocks, where large areas of the skin and subcutaneous tissue are anesthetized by the injection of local anesthetic into certain areas of the skin. For example, hair plugs, scar revisions, and superficial mole removal. Spinal anesthetics may be used for vascular, urologic, or orthopedic surgeries in particular, as well as emergency cesarean sections. Compared to epidurals, spinal anesthetics work faster and last for a shorter period of time. In certain situations, there may be significant surgical advantages to one or a combination of regional anesthetic choices. For each of them, supplemental sedative medication can be given, so a patient does not need to fear being wide awake in the operating room.
Any nerve can have local anesthetics applied to it, so there's nearly an infinite variety of possible regional blocks that can be performed. In some situations, it's clearly medically indicated to perform a surgery under a regional versus a general anesthetic. This is the situation with elective cesarean sections, where the outcome of the mother and the baby is generally better with a regional anesthetic. In other situations, regional anesthesia should be avoided. This is the case with those patients with clotting disorders or infections in the area of the nerves to be blocked. Your anesthesiologist will discuss with you the relative advantages of a variety of regional techniques available to you and compare those with other anesthesia techniques for your surgery. An individualized plan is best, taking into account your current medical status, your surgery, your surgeon, the facility, and the skills of the anesthesiologist. There's rarely a single best answer covering all situations.
On occasion, a procedure may be performed under local anesthetic alone. These types of procedures include such common operations as vasectomies, removal of skin lesions, dental extractions, and laser surgery. Newer cosmetic procedures such as thermage or transcutaneous radiofrequency tissue tightening and some laser treatments are also done under a local. Local anesthetics can be administered through needles or by creams or drops. Some procedures are performed under sedation with or without local anesthesia. Currently, many eye surgeries are accomplished with intravenous sedation and the administration of injected or topical anesthetics on or behind the eye. Many endoscopy, colonoscopy, and upper GI endoscopy procedures are performed using sedation alone. Just because it is only a sedative does not mean there is less risk. In fact, the risk for sedative procedures is about the same as the risk for general anesthetic. Sedative drugs blunt your ability to respond while minimizing the sense of pain. Though rare, a patient can potentially experience partial or complete airway obstruction. For this reason, it is imperative that someone who is skilled in airway management attends all procedures performed under sedation.
So back to the questions. Will I be awake during surgery? Will I have awareness of the surgical event? As you now know, the answers depend upon the anesthetic technique employed. Some patients are awake, as with regional or local anesthesia. Some patients will have awareness of at least a portion of the procedure, such as those undergoing regional or local anesthesia with sedative drugs. A patient scheduled for general anesthesia should not expect to have a significant memory of events occurring during the operation. Patients may have recall of events before entering the operating room, exiting the operating room, or early in the stages of recovery. Often preoperative or initial anesthetic medications confuse the mind's ability to appropriately file memories. If a patient truly fears any awareness factor, it's important to mention this to the anesthesiologist. He or she can utilize additional or alternative medication to relieve anxiety associated with this fear.
You have probably noted that with few exceptions, anesthesia involves establishing an intravenous line or IV. In exclusively local or diagnostic cases, an IV may not be required, but where there is general anesthesia, regional anesthesia for surgery, or sedation, it should be routine. There are several reasons for this. Primarily, IVs are used to administer medications and fluids during the procedure, but they also provide immediate access to the patient should an emergency occur. In the case of a regional anesthetic for surgery, the IV provides a mechanism to shift to a general anesthetic if necessary. This may be required if the surgery takes longer than anticipated, or if the surgery must extend beyond the original boundaries. This same intravenous line is often used in recovery to give medications to manage pain. You may find this ironic since a common question is, why does it hurt to start an IV? The simple answer is, it shouldn't. It is easy, inexpensive, and risk-free to put a local anesthetic at the IV site before starting the IV. Extra fine needles or creams can be used to numb the IV area comfortably. Patients always ask about postoperative pain. They seem to often anticipate tremendous waves of unbearable pain, or conversely, they expect no discomfort at all. Neither of these expectations is reasonable. It is unrealistic for a patient to expect to have surgery and experience no pain afterwards. Patients who are reality-oriented in this regard have a much better recovery time than those expecting to be completely numb. Some pain is unavoidable, but severe pain can be identified and relieved. Often pain complaints are actually anxiety, but a patient coming out from under anesthetic cannot be expected to differentiate the two. As anesthesiologists, we are trained to identify indicators of pain. Increases in heart rate or blood pressure are two common indications of pain. In the absence of physical indicators, anxiety is treated with the use of a sedative or anxiety medication. Incidentally, if anxiety is relieved, we can often reduce the amount of pain medication and consequently reduce the incidence of nausea and vomiting and other side effects. A patient can reasonably expect to receive medication for complaints of pain following surgery. They will usually be administered intravenously. Several different types of medications are available depending on your surgery, the location of your surgery, for example, office, surgery center, hospital, inpatient versus outpatient, that sort of thing, your allergies and sensitivities, and even where you are going postoperatively. There is no universal panacea, that is, no one solution fits all situations, and as you have learned, your treatment needs to be individualized. For procedures involving the chest cavity, abdominal cavity, or the arms or legs, continuous regional anesthetic techniques can be used postoperatively to minimize pain. Epidural catheters can be placed preoperatively and used postoperatively to administer anesthetic or narcotic medications into the spinal canal to blunt the perception of pain yet leave a patient completely mobile. If you have realistic expectations, there is no reason to suffer following surgery. There are a number of anesthetic choices and regional anesthetic management techniques to minimize the amount of postoperative pain. Don't be afraid to ask your surgeon and anesthesiologist about the degree of pain associated with your procedure and what provisions they will make for your comfort.
Let's turn our attention now to what is without a doubt one of the key issues brought up by almost every patient. That is nausea and vomiting following surgery. Those of us over 50 remember anesthetic agents many years ago having a high incidence of directly causing postoperative nausea and vomiting. Ether was particularly problematic. Newer inhalation agents have a vastly lower incidence of causing nausea. Yet some recent studies report that in outpatient settings, nausea and vomiting following surgery are as high as 40%, or 4 out of 10 patients. So how do we reconcile this statistic with the fact that anesthetic agents have drastically improved? The answer is that nausea and vomiting are not due exclusively to anesthetic agents. They're also strongly influenced by anxiety, drugs, means of administering the drugs, or even the use of oxygen. We previously talked about the value of the preoperative visit between the patient and the doctor. If you're anxious, don't hesitate to request an anxiety-reducing prescription to take the night before or morning of your procedure. Nausea and vomiting plummet when anxiety is reduced. The more relaxed you stay, the less the chance of an upset stomach. For patients who have not had food or water prior to surgery, a temporary state of hypoglycemia or low blood sugar can occur and contribute to nausea. This can be remedied by utilizing an IV that contains dextrose, another name for sugar, as a supplement. Nitrous oxide used during surgery diffuses out of the blood and can increase the size of gas bubbles in the body. These bubbles can manifest themselves in your stomach, your bowel, or even the inner ear. All of these alone or collectively can cause nausea. If your breathing is being supported a bit too forcefully by either a manual or mechanical device, it can increase the size of the normal gastric air bubble and cause vomiting. During surgery and into recovery, the choice of pain medications and antibiotics can directly influence nausea. Modifying the choices of medications at the time of surgery remarkably reduces the incidence of nausea following surgery. Certain narcotics and anti-inflammatory medications commonly used around the time of surgery are notorious for triggering nausea. Some of these cannot be avoided.
In spite of any precautionary steps, should you suffer with postoperative nausea, there are medications that can treat it. For example, Zofran and Anzabent were initially developed to treat nausea related to chemotherapy. Droperidol in small doses can be used without affecting the heart, a steroid. Dexamethasone in low doses can also alleviate nausea and vomiting. Not all medications work for each patient. Your treatment needs to be tailored to you, your surgery, your anesthesia, your health issues, and your preoperative medications. Some of these drugs may prolong your stay in recovery because they tend to induce drowsiness. New treatments easing postoperative nausea and vomiting are being discovered on almost a daily basis. The treatments are many and varied. All anesthesiologists have experience in this area. Your anesthesiologist will design an individualized program of anesthetics and supplemental medication in order to give you as smooth a ride as possible. Discuss the plans with your anesthesiologist prior to surgery. By using a combination of medications or altering technique, the occurrence of significant nausea and vomiting can be dramatically reduced.
So when can you be reasonably sure you're free of the effects of anesthesia? Anesthetic agents need to be either processed by the body or removed from it. Some agents are metabolized and excreted, that is, changed by the body into something else and then eliminated in the expired air or urine. Some are blown off as you breathe in the recovery period. The breathing off and elimination of anesthetic gases is the reason for the gradual return of consciousness in the recovery period.
Most often, you will be taken to a recovery room after surgery. There, the nursing staff will monitor your blood pressure, heart rhythm, and the amount of oxygen in your blood, pulse oximeter, as you recover. You may receive pain medication, oxygen, sedatives, drugs for nausea, or other medications prescribed by your doctors. Intravenous fluids will probably be continued if they were used during surgery.